Good evening, everyone, and welcome to our Better Billing webinar series. Tonight's topic is Hot Topics in Women's Health, the new Menopause Health Assessment, item 695. My name's Katrina Pilbeam. I'm the Manager of the Workforce Education and Capacity Building at Western Victorian Primary Health Network, and I'll be your facilitator for this evening. Alongside me tonight is Jade, also from the Workforce Development team. I'd like to begin by acknowledging the traditional owners and custodians of the lands in which we're meeting tonight. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and we commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations. You can view the majority of our webinars freely on YouTube Learn. We'll put the link into the chat of the recorded series. This tonight is our last webinar for 2025. On the screen, you can see a few webinars and events that we've already locked in for early 2026, and registrations are open on our webpage. In the chat, you will find two links. One is for a very short MS form that can help us design our calendar for 2026, and we'd love your recommendations. You may have seen that we've recently launched our Learn and Network monthly newsletter. It's the best way to stay up to date with our latest education opportunities and upcoming events. If you haven't received an edition yet, please subscribe via the link in the chat or scan the QR code on the screen. The editions are released on the first Tuesday of each month. A reminder about Health Pathways, a free online resource with localised clinical and referral information for our health practitioners. The personal accounts are now available, so reach out to the Health Pathways team if you don't have a personal login, and otherwise feel free to access all those resources. A certificate of attendance will be emailed to participants, so please take a moment to check that you've entered this webinar with your full name displayed accurately. If not, or if you're unsure, please rename yourself or type your first and last name into the chat. This will ensure that we can issue your certificate of attendance correctly. This event tonight is being recorded. Please keep yourself on mute. Due to a large number of registrants, we'll take questions through the chat box. Please feel free to ask them at the end of the session, or I can ask them on your behalf. Your feedback is important, so at the end of this session, we will have a short evaluation. Our presenter for this evening is Dr. Ashley from BetterBilling, and she's supported by Dr. Anne Stephenson. I'd like to hand over to you, Ash.
Thanks, Katrina. Hello, everyone. It's Ash again. I'm just going to start with screen sharing. 1 second. Okay, everyone can hopefully see that. If they can't, give me a yell out. We're all good. So tonight we're talking hot topics in women's health, which is mostly around the new menopause health assessment item number, which is 695. So this is something that was only quite recently introduced. And as a lot of us who may do a lot of menopause-based health, or those who are not or don't know how to use the item number, hopefully tonight we'll be able to talk a little bit around what that looks like. I am very graciously supported with Anne Stephenson tonight, who knows all things menopause. So we'll have a little bit of a clinical background as well as a little bit more on the billing component and how those two very much relate. So as Katrina's already mentioned, please go ahead with the questions as you'd like, and we'll get through them all towards the end. So for those who have the first time seeing me on their screen, I'm Ash. I am the owner and creator of BetterBilling, which is an MBS education online platform. I'm also a GP that's based in New South Wales. I also do have an interest in women's health and chronic disease, but also do love my non-clinical role in MBS education. And for those who have not met Anne before, Anne is a GP with interest in women's health and menopause as well. consultation skills coach, which will definitely come in handy today, and a big focus on holistic patient-centered care. So, what tonight we will cover is a little bit around a case presentation that we've created, which is a patient that we've all sort of seen before, and hopefully we can take some information based off this of, when we see someone and we think, oh, that's really similar to the case, that might be what you'll be able to take out of tonight. We'll go through some billing pathways and clinical knowledge for menopause, discussion around consultation skills in this cohort. Specifically, we'll touch base on what 695 is and what the menopause health assessment looks like. We will also have a little bit of a look at the diabetes risk assessment, a little bit on care planning as well, and the heart health assessment. And then from a billing point of view, I'll also mention about the long-acting contraceptive agents like the IUDs and the implanon, which will have a little bit of a change with billing as well. So I will hand over to Anne to start the presentation.
Thanks, Ash. So thank you so much for having me. This is a topic dear to my heart. I've been seeing a lot of people with perimenopause and menopause for some time now, and I feel like my patients have taught me so much in this area. There's so much I can talk about, but I guess I'll start with just the typical presentations. And we're really going to talk a lot about perimenopause tonight because I think sometimes that's the one that really confuses everybody. And a lot of women do get, sort of not validated for them thinking that it's their hormones are not right, or so they go to the doctor and they feel like there's something going on, and they still got their periods, and you know they people can still have their periods and have hormonal symptoms. So that's a really big take home message here. And perimenopause, if it affects a woman, it does tend to be more around their mood, and brain fog, headaches. It's sort of a vaguer presentation than an obvious menopause where the hot flushes and not sleeping. But poor sleep sort of goes into the perimenopause group as well. And they all kind of mesh. It's not like one goes into the other. But perimenopause can go, for 7 years. And, you often hear a story of a woman really struggling so much that, they have to give up their work, marriage breakups because they are struggling so much. So perimenopause is a thing and we can do something about it. Next slide, please. And, often women are asking about having a blood test. And I try to tell women we don't diagnose menopause or perimenopause on a blood test. It's a clinical diagnosis. And and one of the reasons is, especially in the perimenopause, this is a graph showing, and I show this graph to women all the time to say, this is why perimenopause is difficult to manage because the hormones are kind of erratic. They're going up and down, and then you just plonk HRT on the top of it. And sometimes you sort of got too much estrogen, the breasts are really sore. So that's why it's not as straightforward as just giving someone HRT. And also, you could do the blood test, and I've seen that where the estrogen's super high, and that's a classic sign of perimenopause. Um, Saying that if a woman's young, I think it's really important to find if she's got premature ovarian failure, which is, it's not at the top of my head, but I think it's 2 FSHs, which are over whatever the level is. So you do want to pick that up because it's really important that we don't miss that because you're much more at risk of osteoporosis. But yeah, the main thing is the blood tests are not really how we diagnose menopause or perimenopause. Next slide. I use 2 questionnaires, but this one's a great one, which I think is called the Greens AMS, and it's on the Australian Menopause Society website, which is a great website. It's actually just been improved and really easy to find things. So I'm a member, and the other thing about being a member is they list you as being a person who's interested in menopause, and women seek you out, and it is a great thing to do. Like, I love dealing with menopause. It's actually, you get so many wins And as we're going to talk about today, it's this opportunity that you connect with the patient and then you can, go with this patient with the next things, which we're going to talk about with Ash. And she just maps it out so beautifully. But I feel like if you do this menopause part really well, this is your opportunity to really connect and really work with the patient for their health, forever, most of their life. But yes, this is a very good questionnaire for menopause. Not necessarily with perimenopause, but I still use it, and it's a very helpful one because if I start something, I do it again after 3 months, and it can be amazing the difference that someone has after starting something. Next slide. But as I said, perimenopause is kind of different, and often it's much more mood. Like suddenly I'm really anxious, or suddenly I'm just so irritable. Suddenly I can't think straight. I can't get words out of my mouth when I'm in a meeting. Really doubting yourself. So they're the sort of things women present with. Um, and the clues that they might be more likely to get this is if they've had sort of hormonal mood things in the past, such as premenstrual dysphoric disorder or postnatal depression, and they've talked about the hormones affecting them in the past. Next slide. And this, I don't use this regularly, but this is sort of an interesting thing. This is it's called the MENOD questionnaire, and it was developed by Jaya Kulkarni, and she's a psychiatrist at Monash who has been very, very instrumental in getting perimenopause and mood disorders on the table. And she developed this questionnaire, which is the sort of anxiety, depression that manifests with hormones, and it's actually quite different to um, you know anxiety, depression that you might see in other things. So it's just a way of thinking. It's worth sort of knowing rather than go because I usually don't have time to go through this with people. But if you see what I've got up here, irritability and paranoid thinking, they're the kind of things that women talk about. Next slide. Okay, so we're going to do our case now. So meet Renee. She's a regular patient of yours. You've known her. No, she hasn't come in very much. She's 43. She's known to have polycystic ovary syndrome and she's had very heavy periods. And luckily, she's been able to get an IUD in, which has made a huge difference to her periods. I think it's been in for 3 years. And her BMI is 33. The menorrhagia is now okay. Um, and the other thing is a lot of patients might think because they've got an IUD they can't get menopause. They don't realise that's just giving them the progesterone, not the estrogen. And uh, we've done a questionnaire and we found that her Oz risk level is 12. So that means she's at risk of diabetes. So that's our patient. And the perimenopause is irritable. Yes, next one. She's irritable. And the other thing about this type of patient, I've found that perimenopause, they don't come in and say, I think I've got perimenopause. They often have something else, like, I think I need a mental health plan. My marriage is breaking up. There's something going on at work, or, some sort of musculoskeletal issue. There's often a kind of cluster of things that are coming in, and then, your job is to sort of uh, untangle that, and then do some shared decision making of what the next steps are. Ash, you're on mute. You're muted.
Oh, you got me. You got me. All right. So I'm going to take over a little bit from this point about the journey that we're going to be taking with Renee, a little bit on the billing component and what this is going to look like. And we see patients like this quite often. So we see Renee, and Renee came to see us about this knee pain. It's been ongoing. She's really not liking it, stopping her from exercising. She wants to lose some weight, etc. And so as a result, we end up seeing her for the knee pain. We assess it. We decide what this might be. And then she drops I really kind of want to talk to you about perimenopause too. And this is around minute 17, where you go, okay, that's a really long-winded conversation. I want to have it with you, but I want to have specific time for it with you. And so in this particular case, you end up seeing Renee for her appointment, and you charge her a private 23 because in this case, you've just discussed the knee pain and you've made plans to have the perimenopause health assessment. Now, in this particular case, I will often go through this where I'll dedicate the entire appointment to her perimenopausal health assessment. Now, in this particular case, personally, I will often bill a 965 privately. And then depending on what that brings up, which we'll go through in a little bit more fine details, we look into future other appointments and future other opportunities. So let's have a little bit more of a look here. Oops, 1 second. Okay, so the 695 health assessment, which is the menopause health assessment. Now, this is a bit of a summary of what the MBS is wanting from this health assessment. So the patient needs to be female and have clinical features of either menopause or perimenopause. There is no age range in this, okay? The time requirement is you need to spend at least 20 minutes with the patient. Now, that time requirement can be spread between yourself and your nurse. So if you're someone who's seeing patients in 10, 15-minute blocks, but you want to do a perimenopausal health assessment, you can absolutely get your nurse involved to do part of the health assessment. I quite often do, and I'll show you about how that looks in the next coming slides. In terms of the requirement, the MBS has quite clear requirements of what they want to see in a health assessment in order to fulfill the item number. So the first is it needs to be quite a comprehensive history. So in terms of menarche, when did they first get their periods? What have they been like at the moment? Have they ever had any surgeries, gynecologically? What's their family history look like? Has there ever been any other related cancers that we need to know about, etc.? There will also be a specific spot around menopausal stage assessment. So are they perimenopausal? Are they menopausal, postmenopausal? Are they surgical menopause? And making that really clear. There needs to also be a specific spot for discussing vasomotor and psychological screening. So talking about their symptoms, and quite often, like Anne's mentioned, is using the AMS questionnaire. It's very clear. It's really easy. 0 to 3, people feel like they can understand where they're sort of sitting, and you can repeat it really, really easily. Another thing is also having a chat around their current medications, what their medication looks like, and also doing a cardiovascular and cancer risk review. So are you going to be talking to them about their cardiovascular risk percentages as well as things like their lipids? When were they last done? Are they pre-diabetic? Are they not? Are they at risk of diabetes, etc.? And then cancer risk review. And this is mostly around their preventative screening. So specifically, we're asking about pap smears or CSTs. We're asking about mammograms. We're asking about bone density scans. Have they had them before? Do they fit the criteria to have an earlier one? And also making sure if they haven't already done their FOBT or bowel screening, that's also needs to be up to date. And using this health assessment is a really good way of making that be clear and up to date in terms of your notes. It also needs to be a very individualized management plan. So discussing with the patient specifically what they would like is really important in terms of the management plan. So just ticking to decide, yep, we'll do we'll do MHT, we'll decide on SSRI, whatever that might be. Just making it really blank and a bit of a tick box is not what they're actually requiring or wanting out of this health assessment. Lifestyle advice and assessment also needs to be a really big part of it. So going through that SNAP, so the nutrition component, their exercise component, their smoking, their alcohol consumption, and thinking about different ways to help reduce those unhealthy habits, especially during this time period. Providing a written plan is also very much in the MBS's rulebook, is being able to provide one to the patient if that's what they are interested in. So how do I do my health assessments in terms of templates? So anybody who's done any of my talks knows that I'm a big lover of AI, and Lyrebird is particularly the one I quite like. This here is a template that I have created that's through Lyrebird. So this is purely what is created for me based off the discussion with my patient. So I'll be able to have a chat with them about each part of the menopause health assessment, and based off their discussions, it inputs and creates a document for me that is literally for their menopause health assessment template. It's very clear. It fits the entire criteria, and if you're already using AI systems such as Lyrebird, it's a very easy grab, which you can find online on my website in the free resources template. The other on the right-hand side is a template that I have made for those who do not wish to go down the AI road yet, or want to be sort of using letter writer or getting their nursing staff involved. And this is also available on my website as well for free. And it's the menopause template health assessment, which pulls details from BPs particularly, but also gives you those really clear prompts about what needs to be discussed. In here, this is specifically split for both my nursing staff and myself. So for my nursing staff, I might get them to accumulate some information such as their menstrual history, their last periods, their medical surgical histories, and then also going through the MHT contraindications checklist, and then also doing that baseline, the AMS screening questionnaire as well. And that is included within that template itself. Using either of these templates will absolutely make sure that you fit the criteria of the MBS for item number 695. So if we have a look at Renee, this is one that I created just by talking into my Lyrebird so that it could create something for me for this. And this is just something that I was be able to do based off this case. And so you can see here in terms of Renee, it's got her age, perimenopausal assessment for this lady who has a BMI of 33. She's got her IUD in for the last 2.5 years. It's been very effective. She has PCOS, what her current medications are, what symptoms particularly have been concerning for her, a physical examinations of what have we been able to do, discussing her screening status. So her pap smear is up to date. She had it with her Mirena insertion. She's not due for early mammogram or early bone densitometry, and she doesn't have any indications for earlier FOBT screening at this stage either. We also discuss weight loss and exercise, that she's mostly hoping to look for that to improve her mood because she's noticed it before. Then also we've discussed a little bit around her cardiovascular risk percentage. We've also been able to either have a look that her lipids have been done in the last 6 months, and we know where that's at. And her HbA1c was also done about 6 months ago because she'd kind of come in with a little bit of a fatigue history, and we can see that she's in that non-diabetic range. So in terms of discussion, we discussed a hormone replacement therapy for her, as a particular management option. She hasn't ever previously had hormonal therapy except for the contraceptive pill in her early teens and 20s, and she's got the Mirena. And so having a little bit of a look at this has been created for me from my Lyrebird as an option, and that's what our patient specifically looks like from here. However, during this assessment, we were able to do an OSRISK. So the OSRISK score is the score that helps us to decide on the risk of diabetes in our patient. The screen on the left-hand side, this is what it looks like in best practice. So it's built in within our software, and under clinical in the calculators, you'll be able to see specifically where you do the diabetes risk assessment. Pops in a lot of the automatic information from BP, like are they a smoker? Do they identify as Aboriginal, Torres Strait Islander, etc. But what we will be able to see here is in our patient Renee that she has scored a OSRISK of 12. Now, the implications of an OSRISK of 12 obviously means one, they're a higher risk of actually developing type 2 diabetes, but also in terms of further other health assessments that are on offer. So if we have a little bit of a look at here, after our perimenopausal health assessment, we've done that as a 695 privately, which is absolutely able to be done. So this is a health assessment that can be billed privately or public or a bulk billing, however you prefer. However, based off this discussion, we've been able to decide that that Renee is also now a patient who is at risk of diabetes with her Oz risk of 12. And we decide on our follow-up appointment, we're also going to be using that to explore a little bit more on terms of lifestyle changes. And appointment 3, as you can see here, I've split into 2 different options. So we've actually initially going to get Renee to see our nurse to start with, who's going to do the at risk of diabetes health assessment. And then after that's completed, we're going to have a chat with Renee after looking at the health assessment, seeing some of the findings, getting into that nitty gritty around exercise, diet, those things and those goals that she really wants to be able to achieve. And then also, which we absolutely can, is we're going to be completing her care plan for a patient who is active, who's currently has PCOS as a chronic health condition. So in this case, this is a little bit about the 705 in terms of the diabetes risk assessment. Now, this particular case here, you absolutely have to have an OSRIS score of 12 to be able to access this health assessment. The patient also cannot have a previous diabetes diagnosis. So they can't have been diabetic and somehow resolved and then now are getting a repeat assessment. They need to have no previous diagnosis. They also can only be done once every 3 years. Okay, so this patient can only have this happen once every 3 years. It cannot be an annual situation. The patient from an MBS point of view, you absolutely have to review your OSRIS results. You need to see how high, how high are we? Are we 12 or are we 22? We're talking about risk factor history, which we'll go through in a second, her metabolic measures and physical measures. So what's her BMI, what's her waist measurements, what's her blood pressure looking like, a discussion around cardiometabolic discussion. So talking about her lipids, her HbA1c, also talking about the relevance of, say, waist circumference into her risk here as well. And then we're essentially creating a prevention plan. And that's where I kind of come into the template that I often will use as well. This is also absolutely available for free for anybody on my site. You'll be able to see under the free resources. And this is one that's been particularly created for medical director or best practice. So this pulls the information for your patient based off their details from BP. And you'll see here, this is the eligibility that we need to be able to fit for this patient to have the 705, so what was 705, 707, depending on time, for their type 2 diabetes risk health assessment. And so the patient needs to be between 40 to 49, which Renee does. We have completed our OSRISK assessment tool, so that's a yes. The OSRISK is more under or equal to or more than 12, which we absolutely have been able to fit. She's not been previously diagnosed or is currently diabetic, and there's been no other recent health assessments within the last 3 years. Now, in this particular patient, we'll be able to see here, so 12 or more is high risk, 20 plus or more is that person has a 1 in 3 chance of developing diabetes within the last 5 years. It also gives you a bit of a prompt here that if it's under 12, stop this assessment because it is not going to be able to fit the criteria for Medicare and you will not be able to claim this item number. It will pull a lot of the previous details from the file, like medical history, family medical history, current medications and allergies. And then this is the specific part that I really provide to my nursing staff to go through with the patient. So having here a look in terms of their weight and measurement, that will pull in the observations directly as well. Then a bit of an area for smoking and alcohol. Are they currently vaping? What is their current alcohol consumption? And then what you'll be able to see here is all of these yellow highlighted areas. Now, from the legend that's at the top of the page, the yellow ones is what really require you to actually create with the patient or to actually input information. So discussing things like how many veggies are you having a day? How much fruit are we having? How much dairy? How much lean meat? Do we eat a lot of sugar? And then also creating goals based off of the specific risk factors that we're talking about in terms of preventing diabetes. So is there a particular goal that the patient has around weight? Is it around BMI? Is it around waist measurement? Is it a size? What would they like to see happen with themselves? Blood pressure, do they have a particular goal? In terms of smoking or vaping, obviously we want smoking cessation, but does the patient just want to cut down to 10 from 30? What are they looking for? Then here on the right-hand side, you've also been able to see that this provides you with a little bit on discussions with the patient that have already happened. So for yourself, that might be around talking around measurements, getting them done, or repeating your weight, blood pressure, etc., every 4 months with the nurse, which would be one option. There's also some links in here which are very active links. So talking about the DASH diet for those with hypertension, the quit smoking app, which is really helpful, the Getting Healthy service if they are looking to cut down their alcohol, or their Australian healthy eating guide, which is another option as well. So in this case, Renee meets the OSRIS criteria of 12, but what if it was 10? So if it was 10, she does not fit the criteria for the 705, the at-risk health assessment for those within the age range of 40 to 49. However, we can consider a 699, which is the heart health assessment. Now, the heart health assessment, I often get told, Ash, why would I ever bother? It's bulk bill. I have to bulk bill it. It's more than 20 minutes. And I can see a patient for a level C and bulk bill them down and attract the triple incentive. And absolutely, you're completely right. So in this particular case, I tend to use this only when I'm co-billing. I have only ever done one 699 as a standalone appointment. However, all of mine have been often co-billed with care plans or care plan reviews. So in this particular case, we'll just quickly run through what the requirement is of 699. So the heart health assessment item is for patients above the age of 30. What is required in terms of the MBS's requirement for a 699 is this relevant history and risk factor taking information. The basic physical exam needs to include a blood pressure and cholesterol. So if you do not have lipids already for your patient, you cannot be claiming this item number. If you have no lipids on file and you provide them with the form, but you haven't been able to actually complete the assessment with active recent lipids, then you're not going to be able to claim a 699 completely. You also need to calculate the risk using the OSRISK, the Australian Absolute CVD Risk Calculator, which is very much available within best practice, but it's also available on its own website. And it's very clear, very nice to explain what we need to do based off our percentages for patients and their risk of having stroke or heart attack within the next 5 years. Based off those results, discussing with the patient, what should we be doing? Should we be looking for really quite rapid weight loss? Are we worried about are you really high? Are you 15% risk? Are we concerned? Do we need to look at statin medication, controlling blood pressure more stringently? What is the plan? And then also providing preventative health advice. So that might be increasing your exercise to 3 times per week, trying to make exercise a priority every day, whatever that might be. In terms of eligibility and frequency, so like I've mentioned, it needs to be your patient needs to be more than 30. This health assessment you can claim every year. So if your patient persistently does not fit the criteria for any other health assessment, then you can do this one every year. You cannot claim it with other health assessments billed in the last 12 months. However, the 715, which is the Aboriginal and Torres Strait Islander health assessment, that can be billed in the same cycle for this patient. This here is a little bit about how I do my documentation for my heart health assessment. So again, this is just one that I've made with my my Leeuwestyn, and you can see here I've done a health assessment for this patient. And the heart health check toolkit, which is through the Australian Heart Foundation, has an absolutely awesome PDF that you can use for your heart health check. It's down to 3 pages. It fits exactly the relevant information that you need. And you can see it also pulls a lot of the information when used in Leeuwestyn, pulls a lot of the information that you're able to have with those discussions with the patient, really reducing the document load of what you need to do. If your nursing staff are helping you with the healthy heart check, then I really encourage you to have a look at those online. They're PDF. They also have the RTF versions, which are directly importable into BP and MD. All very awesome resources to use and fit the entire criteria for the MBS as well. So I just give you this slide as a bit of a recommendation because there's a lot of confusion around what I call the health assessment roulette. Which one do I choose? What do I do? Now, if your patient ever has a heart health assessment or a 699, they can continue to have a 715 done within that year. They can absolutely have the menopause health assessment as well. However, the 699 will actually block out any of the time-based health assessments. So, for instance, if your patient is at risk of chronic disease at age between 45 and 49, or if all of a sudden they become at risk of diabetes, like one of their parents has now been diagnosed and they've got a first degree relative, or they remember, oh, I forgot to tell you, I did have gestational diabetes, whatever that might be. If it's not been done within that 12-month, if it's been done within that 12-month period, your patient will not be able to access those time-based health assessments. Okay, so when I say think about the 699 in that patient cohort between 40 to 49, it's mostly to decide whether the patient is more relevant to have an at-risk of diabetes assessment rather than the heart health assessment. And last bit of talking for me for a bit is around the chronic disease management plan. So for any of you who have seen any of my care plan webinars or any of the courses online, you would be able to see that care plans for me particularly are mostly done through AI systems because of how fantastic they are at pulling out really effective goals and really fitting the criteria for me from an MBS point of view. And so having a look in our terms of our patient, Renee, she has PCOS, and PCOS is a chronic condition. So fitting the criteria of a care plan very easily, which means that the patient is either had the condition for more than 6 months or they will likely have their condition for more than 6 months. The other criteria in a separate case would be if the patient is newly terminal, they are absolutely able to gain access to a chronic disease management plan or a GP CCMP. In terms of what they would need to be thinking about, so in the case of Renee, we would need to be having a look in terms of what her history is and her PCOS symptoms, looking at her assessment of her metabolic risk as well. So thinking about adding that in as goals for her care plan. Is it around weight loss? Is it around exercise tolerance? Does she want to, finish a marathon in the next 10 months, whatever it might be? Or is she, just looking at controlling her perimenopausal symptoms? Also an absolute goal in this particular case. But goals need to be, as I've always preached, very specific to the patient. They cannot be a couple of word sentences. They need to almost tell the story of your patient, of what you've discussed with them. Okay. And from a billing point of view, this 965 or the care plan item numbers can absolutely be done with a 695 or a menopause health assessment if that's what works for you better. And it also can be done at the same time as a 705. So if your nurse has been able to complete a complete 695 or the 705 health assessment for you, and you've completed a care plan or vice versa, it's absolutely fine to be billed on the same day. I will hand back over to Anne. Oh, you're on mute now too, Anne.
Well, it's just the cats meowing out there. Oh,
what? Hang on. Let me just go back 1 second. Sorry, guys.
oh, good. I can talk while, yeah. So I guess, there's so much information there, isn't there? And I do think, I've joined Ash's, Better Billing, and that's really helped me kind of have in my head where all the items numbers and what I can do. But then my feeling is we have to be careful that we don't get snowed under with all these things so that we kind of overwhelm a patient. Um, and so I wanted to talk a little bit about a patient like this and how I might approach the consultation, because certainly perimenopause, PCOS, these are all kind of high stakes opportunities to connect. And I think often patients who might have excess weight with PCOS can actually find negotiating medical practitioners quite difficult, and they can have felt that they've been shamed for their weight, or and it's a difficult disease, hairy, put on weight, so I'm very, very careful about how I validate these patients and really put a lot of energy into connecting. And I really think it's so good you can if you know about all these health assessments you can do, but I'm my number one thing is to connect with the patient and then do a shared decision about what we do, one thing at a time, not try and do everything at once because it's overwhelming enough. I just brought this model. This is a consultation model. There's so many consultation models out there, but I like this one because it's so simple. And I think this is a really nice way to think of when you do a consultation. Invest in the beginning, really think about how you're showing rapport to that patient and showing them that you're seeing them and you're there and you're really active listening at the beginning. Those first, once you know a patient, I guess there, you've already done that. But with a new patient, just making sure really look at them and chat to them as they're walking into your room. These are just really tiny things that can make a huge difference. When you're hearing about what they've come in for, which with Renee, it was a sore knee and some mood issues. Just making sure you really find her perspective. What does she think's going on? What's she most worried about? What is she hoping to get out of this consultation? Really making sure that's what ICE is. I've put that little box there. I use ICE all the time to just make sure I'm clear about what they are most hoping to get from the consultation before you start doing all your checklisty questions because and that's probably my only concern with all these health assessments and so on. We can get very checkboxy, and I think that they have their place, but I think the first of all, the patient needs to feel like you're getting their perspective. I put emotional cues because they come up in a perimenopause consultation every time. Like I had two today, both in tears. One was, she's burst into tears, and hers was about because she was 54 and she was really annoyed that she wasn't helped when she was 45. She quit her job because of perimenopause, and she's just really pissed off because now all these women in this age are getting help, and I didn't get the help, and I had to go and see about six doctors. So if I just moved on from that, this is the first time I'd seen this woman, but just to really validate, how difficult that time was and how, obviously there's grief that she didn't get what she needed at that time and how much that's affected her life. And, um, she actually finds it very hard to see a doctor now. So that just to show some praise that it took courage for her to try again and see a doctor. So, nurse is an acronym that talks about how you might respond to emotional cues in the room. So, Anne is just really noticing, and you don't necessarily need to name the emotion, but in your head, you're going, "Oh God, it sounds like you're really frustrated or such." And you is, well, that makes a lot of sense. It's understanding. R is respect. S is showing support, and E is explore or explicit empathy. And so again, that's like a crucial thing that can make a huge difference to the connection to the patient in front of you. And the other thing is invest in the end. Often I think when we try and do too much in a consult, we never leave ourselves enough time to just work out the plan for the next visit. So don't try and do everything. I think women are particularly bad at this as female GPs. We try and do everything and solve every problem that the patient gives us. Um, so the invest in the end could be as much as, look, like there's so much to unpack here. I really want to help you. Let's make a plan for a few appointments. Let's use Medicare so, I can, if that's what you want to do, bulk bill you for some of these visits. But I have to, use these Medicare items so that I can do that. That's how I talk about it. But I'm very clear that, we have to plan for it all. Next slide. I just there's so many micro skills that can help you in your consultations, but I thought this is one that I love and I think it's underutilized. It's called a formative summary. So when a patient comes and just tells you blah and you've kind of got their perspective, you then say, okay, I just want to check I've got this right. This is what the main issue is. And, and anytime you don't think I've got this right, just tell me, but this is how I see your main issues are, and this is what you're really hoping for. And, let's work this out together, or this is how I think we might work through this. So it's just sort of making what's implicit explicit. And it's really helpful for yourself as well to work out what you do next. You sort of think out loud. It's such a great thing to practice and do. I do it every day. It's very useful. So next slide, please. So perimenopause. This is out of the Monash toolkit. I think, yeah, the Monash toolkit for menopause, which is I put that resource at the end, and they've got some really good algorithms around, how to work out where someone is and so on. And this is a how to manage perimenopause, because perimenopause is trickier than menopause. Um, so really the easiest thing is the pill, and depends what's the patient demographic is. If their BMI is over 30, as is Renee, you can't use the pill, or they've had clots, or um, there's, the contraindications to the pill, you can't use it, but it's many women you can, and it's really safe. And many women really do need contraception at this time, but they don't think about it. But often talk about using it if it's right for someone as an experiment, because so many women, oh, I'm not going to go on the pill. I don't want to go on the pill. So, sometimes I'll say, but yeah, if we just give it a go, we might get a sense of, how much is this is mood or not mood. And so Nextstellis is really, really helpful for the heavy periods. So I use that quite a lot. And now that's on the PBS, which is fantastic. Um, so Yaz, I don't tend to use the Levelins. I tend to use Yaz or Nextstellis. I really love Zoli, but that one's expensive. That one, I mean, that's what Jayashri Kulkarni likes for mood. I wish they put that one on the PBS. Um, then we've got the Marina with continuous estrogen, which is, of course, we all love that if we can get a Marina in, which Renee's got, which is fantastic. But it's getting it in. And the only other thing I'd say about that, just talking about risk, PCOS and increased weight, that woman is much more likely to get endometrial cancer. I think it's 3 times, and I think a lot of people don't think about that. So a bigger woman who can't have the pill, who's had heavy periods, like if I can get them to get a Mirena, sometimes it takes a bit to get them there, but I think often when you tell them, well, you're 3 times more likely to get endometrial cancer than somebody else, that often gets them there. Um, and then there's the continuous estrogen with cyclical progesterone, which I absolutely hate. It gets a bit messy, and then, sorry about that. But look, the thing is, people try and kind of get it to work through their periods, and then because their periods are regular, then they don't take the progesterone. So, it takes a lot of explaining, I find, but sometimes that's what it takes. And then you've got like Slender, and they're saying cyclical Slender with, um, which I don't. Sometimes I will put someone on Slender and I'll add in some topical estrogen, but again, that's sort of to just get a sense. It's not like my favorite, but sometimes to get an idea of how much this is mood. So next slide. Renee. So we've got an IUD. Yay. That's so good. And the IUD is only going to last for 5 years for the hormonal element. but that's going to manage her menorrhagia. The other thing is sometimes I've found the Mirena might run out a little bit earlier than 5 years. So if they start bleeding after 4, sometimes it's good to put another one in, which is PCOS. You don't grow out of PCOS because PCOS isn't an issue with the ovaries. It's actually a metabolic disorder. So PCOS is just a metabolic disorder that causes cysts on the ovary. So some women think, oh, well, I don't have PCOS now because I've gone through menopause. Well, actually, it's not a disorder of the ovaries. I think they're going to change the name. Um, so we go through all the things that are bothering her the most, and you know and then measuring that, and then re-looking at, and then I guess it's looking at her risk factors and what we do about that. So we've got the metabolic risk, and we've got the lipid risk, cardiac risk, and then the lifestyle counselling, um, which again, I'm really gentle with that. I'm not checklisty. I don't know whether that, really try and find out what's important to a patient. And another thing about PCOS, I love to say to patient, like this is not your fault. Like this is a genetic thing that uh you've inherited that makes this happen, and it's not easy to lose weight. So this just lose weight thing. So I really, really validate the patient. And a lot of patients, you just see them relax, like, oh, okay. They've just been giving themselves such a hard time. The metformin. There's also inositol. I don't know if people know that's a sort of herbal supplement that works a little bit like metformin and doesn't have the gastrointestinal side effects. Um, I'll often use oh, can't think of the names. Don't worry. A tablet for the hirsutism and the acne. Um,
Spyro.
spironolactone. Um, but yeah, this is a journey. Weight management support. We don't want anything to happen quickly. We're going to work together, and then thinking about how you might use um, your item numbers to do this motivational interviewing, shared decision making. They're kind of clustered together. Next slide. Ah,
So I will just quickly mention a little bit about the last bulk billing or billing changes overview. So since November, we've had some substantially higher rebates for our existing LARC items, which is so good. So many more women I'm finding are starting to come in because they want to have that Marina because they were previously priced out of it, but now they're back on, which is great. And so I also just want to make a quick mention about the bulk billing loading item number 35501, which actually adds 40% bonus for yourself if the LARC item is actually bulk billed. So in particular, the item numbers I'm talking about is 14206, which is now a rebate of $100.40, which is the Implanon in. The Implanon out is 30062, which is 105.15. There has been some recent clarity from Medicare as well about billing those item numbers together for Implanon in and Implanon out, which previously was not able to be done, but that absolutely is now able to be done, which is a really good option because a lot of us are now able to provide that a bulk build for the patient. The insertion item number for the IUD is 5503, which is at 100% to 215. In these cases, you'd be getting 85% of these fees because these are procedures that are done in a general practice environment. And then the bulk billing incentive load, which is when either of these item numbers are bulk billed, 40% loading is given to yourself for doing them completely bulk billed. The item number itself needs to be bulk billed to be able to add that incentive item number. So if you haven't already, do the maths. I personally am now bulk billing all of my LARCs, all of my IUDs and Implanons, which is really good because we've got so many women that have been desperate for one that can now have one. Other thing, yeah, so just be wary of it. If you haven't already, have a look at it and see if it's an option for your practice as well.
oh, back to me. So I just wanted to say a few words about motivational interviewing and shared decision making. They're kind of connected. And um, I think it's just like really validating the patient and trying to find what's important to them and them knowing their risks, though. I think, you don't want to avoid, the risks that someone might have, but leaning into it in a way that, you know, gives them autonomy. If we give too much advice, we're taking away people's autonomy. So, build that relationship, really validate the patient, be really curious about what it is, they want to work on, and try and find a way to support them to make those small changes, whatever that might be. I put this photograph of Maya Angelou because she's she wrote this quote that really speaks to me, which is a, a person will never forget will forget what you said, but they will never forget how you made them feel. So that's kind of something I take with me. Like, if you show a person they're seen, heard, understood, and you're there to help them, that's motivational interviewing, shared decision making for me. It's not it's not hard. So that's next slide. Um, yeah, I didn't know. I'm not sure about where to put this, but the iron deficiency is common in perimenopause. I suppose this going backwards a bit here, but a lot of patients that have heavy menstrual bleeding, so screen for it, and you know, it can make a huge difference to how they're feeling if their iron uh, levels get back up again with whether it's oral iron or an iron infusion. I mean, iron infusions are great, I think. You get a quick win with them if they want to do it. Um, and from my understanding, that can actually help the periods not be as heavy, if you replace people's iron. And I think, yeah, the IUD, if they're bleeding that much, they're really iron deficient, then I think, explaining that we really have to do something about these periods. It's just going to happen again. And I think, have we got some billing ideas about this, Ash?
We didn't in the case of time because we
Yeah.
have 4 minutes left, which is pretty fine for us. But I'm sure there'll be many other future opportunities.
Thank you. So Jade has popped up the session evaluation for today, so please take the time to complete that. We've also got, which will pop the link into the chat, the RACGP feedback, which it's not compulsory that you complete it, but if you'd like to give any feedback on the 23-25 triennium, feel free to do so via that link that we've popped in. I'd like to take the time to thank Ash and Anne for tonight's presentation and hope everyone, it's our last one. So we'll see you all back in 2026. So thanks everyone. Thanks Ash.
Perfect.
Thanks Anne.
Thanks,
No
guys.
worries. Thank
Bye.
you. Bye.
Bye.